Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Jeffrey Thomas. Dr. Thomas specializes in neurosurgery, cerebrovascular neurosurgery, and interventional neuroradiology. His practice is unique in its integration of microsurgery and minimally invasive catheter-based endovascular neurosurgery for cerebral aneurysms and other vascular brain lesions. Dr. Thomas was recruited by Washington Hospital in 2011 to lead the development of a comprehensive center for cerebrovascular, neurointerventional, and stroke surgery based in the East Bay. He earned both his undergraduate and medical degrees at Columbia University in New York and completed his internship and neurosurgical residency at Columbia Presbyterian Medical Center and the University of Southern California. His fellowship in interventional neuroradiology was completed at Thomas Jefferson University Hospital in Philadelphia, and his research fellowship at the Cardiovascular Research Center of the Massachusetts General Hospital in Boston. Dr. Thomas is certified by the American Board of Neurological Surgery and serves as the medical director of interventional neuroradiology at Washington Hospital. Dr. Thomas practices at the California Center for Minimally Invasive Brain and Spine Surgery with Washington Township Medical Foundation in Fremont.
So let's get started. What is a cerebral aneurysm? That is a cerebral aneurysm. It is a bulging on the wall of a blood vessel. Most of the time, we do not know why they occur. They are associated with a weakness in the arterial wall. And that weakness, over time, can grow until we have something spherical like that. Okay, so anyway, that round ball is the aneurysm. And as you can see, it serves no purpose. It's a blind sac. And you can also imagine that with a certain amount of growth, the wall of that sac would get more and more thin until one day it finally bursts. The problem with cerebral aneurysms is that we often cannot detect them until they actually do burst. So the usual story is that someone has suddenly gotten dramatically sick from a cerebral aneurysm rupture. And the cardinal symptom of such a rupture is the sudden onset of a very severe headache. So, as I was saying, a weakness or bulging of the arterial wall in the brain, it is usually not detected until it ruptures. So the numbers are that 80% of aneurysms are diagnosed after they actually bleed. Once an aneurysm bleeds, there is great danger. A patient is in trouble. That becomes an urgent neurosurgical situation. A lucky 20% of patients have an aneurysm diagnosed before it ever bleeds. Those 20% of people who have it diagnosed before it bleeds are people with migraine headache disorder or got in a car accident or had a scan for some other reasons, at which time the aneurysm was detected. Cerebral aneurysms are dangerous when they are ruptured. They are associated, unfortunately, with a 40% mortality. So that is with a very successful surgery. So surgery is almost 100% successful, and I'll explain to you the different kinds of surgery that there are available. But even with successful surgery, it is that bleeding event that makes people so sick. And what the surgery does is it prevents the bleeding event from happening again, but once that bleeding has occurred, the patient is very sick and in danger of death. Treatment options, once that bleeding has occurred, are surgery or no surgery. And we'll discuss why that is usually a simple decision, but sometimes it is a complex decision, as when we find an aneurysm that has not yet ruptured. Because in that situation, we're discussing pretty sophisticated and dangerous surgery to treat something that might never rupture and might never cause the patient a problem. So that's quite a discussion to have. This is what aneurysms look like under an operating microscope. It is a big round ball. Here is the native artery that was associated with that aneurysm. That's the artery that it grew from, and now it has grown much larger than the vessel. For those of you on that side of the room, maybe I should use this. Oh, you can see much better this way. So this is the aneurysm. You can see this yellow plaque. This is atherosclerotic plaque, similar to what we get in other areas of our body, like the heart, when things like cholesterol and high blood pressure are involved. This is the patient's optic nerve, and this is the carotid artery here inside the skull. Here's what an angiogram looks like with an aneurysm on it. These are normal blood vessels, all of these, but this ball right here is an aneurysm. And as you can see, this ball is at the splitting point or the bifurcation of cerebral arteries. That's often where we find them. This page is taken from the Brain Aneurysm Foundation, which is a resource for you. Brain Aneurysm Foundation is an organization that's dedicated to detecting and preventing the rupture of cerebral aneurysms. And this document goes through the definition and risk factors of cerebral aneurysm. Basically, the risk factors are cigarette smoking and high blood pressure. And cigarette smoking actually much higher risk factor than high blood pressure. There's also a family history of aneurysms, and that's even though it's not a large percentage of aneurysm cases, it is a serious thing if you have 2 family members or more who have had ruptured cerebral aneurysm. That's a reason to get screened. As a matter of fact, even if you only have 1 family member who has had a cerebral aneurysm diagnosed or ruptured, that is a reason that insurance companies very often will pay for those expensive screening tests that I mentioned. Who gets cerebral aneurysm? It's estimated that about 1 in 50 persons has a cerebral aneurysm. This is a very short list of some famous people who have or have had cerebral aneurysms. As you can see, a number of these people, like Quincy Jones and Joe Biden, have had 2 cerebral aneurysms, and that's an important thing to know about cerebral aneurysm, that if you have one, there's at least a 15 to 20% chance that you have another. So many of the unruptured aneurysms that we actually end up treating are the second aneurysm in patients who have already presented with a rupture. So we bring them in, it's an emergency, we treat them for the rupture, they live, they are well, but during the course of that treatment, we diagnose the second aneurysm, and then they come back for an elective surgery for the second. So in this list, Albert Einstein is cheating a little bit because he really had an aortic aneurysm. It's not quite the same thing, but the rest of these people had subarachnoid hemorrhage or cerebral aneurysm. And then there's this handsome guy here who's in our audience today, and this is what he asked me before I took him into surgery. I answered him in the affirmative. I think I said most days, I know. He turned out okay. when you discuss cerebral aneurysms, how well people can turn out. In fact, there's a reason why I chose this specialty within neurosurgery, because you can really cure people, and it makes a big difference to me, even though the danger at the beginning is very, very great, and there's a lot of drama, and it's very scary, but at the end, you have patients who are actually cured, and that is a permanent situation, and one that I'm always grateful for. Now, this is another patient who presented with an unruptured cerebral aneurysm. And as I told you, most of the time, unruptured cerebral aneurysms are silent. There's no way for you to know that you have one unless you get a scan by luck or chance. But this patient was different. His aneurysm was so large that it was actually causing him neurological symptoms, and that's how he came to medical attention. Now, I'm showing you his case not only to illustrate the kind of symptoms that someone with a giant aneurysm can have, but how we were faced with a choice about what technology to use. And I'll talk about this a little bit more, but we can operate on cerebral aneurysms by a couple of different methods. And the technology that is available to do so is always moving forward. It is a remarkable advance of technology. We can do brain surgeries now from a tiny incision in the leg without opening a man's skull at all. And people will look like you haven't done anything to them at all. And that is a great resource. It's not always the best way to go for a patient for reasons that I will explain, but that kind of technology is now available here at Washington Hospital. And the reason that's a big deal is that this is a community hospital. Historically, community hospitals don't have these kinds of resources. This is the kind of surgery and the kind of treatment that is usually available only in the great big university-affiliated academic medical centers. And now you not only have it in this community hospital, but you have it for the first time in the East Bay.
In September of 2006, when I was walking over in Lake Merritt Park near my home, I noticed that I was starting to limp on my left leg. My aneurysm was located in the basilar artery, and
here's his aneurysm
hammering
here.
Against the basilar artery, which is
It's calcified like bone,
what was causing my symptoms.
right in the middle
Both
of his
my arm
brain.
and my leg were affected. I had left-sided paralysis. I had little use of this arm. I couldn't do this. Back then, I couldn't put my hand on top of my head. I couldn't shower like this with my left hand. I had no idea what the danger of this aneurysm might be. I didn't know anything about aneurysms when this was diagnosed. And Dr. Thomas, when he spoke to me after the angiogram here at the hospital, he immediately set me at ease and explained everything to me, which made me feel very comfortable about my situation. He did two things. First, he put a stent in the artery below the aneurysm, which I think he wanted to place to strengthen the artery at that point and also facilitate the procedure which he recommended that I have, which was called coiling. There was a period when I had to tell myself, I'm not going to get discouraged. I'm not going to let this upset me or depress me. And I knew from my experience working with cancer patients that a positive mental attitude is one of the most important things. And I had very good care all the way with Dr. Thomas, with Dr. Rose, with my physical and occupational therapist. All of them were excellent.
So what that patient's referring to is a stent. An intracranial stent is something that bolsters and reconstructs the wall of an artery. I meant to actually include a video that I forgot to put in the presentation, but it shows that through that same tiny incision in the leg, and I'm talking about a 2 or 3 millimeter incision, you can go all the way from the leg, through the chest, through the neck, into the head, into the brain, into the artery that is harboring that aneurysm, and put the stent across the base of the aneurysm. Once that is done, you can take another tiny catheter, steer that all the way up through the stent into the aneurysm, and then put in these platinum microcoils, one after another, until the entire aneurysm has been filled with platinum. Just to give you an idea, Coils were used for the first time in a human being in 1991. Intracranial stent was used for the first time in 2004, FDA approved. So you're talking about technology that is that's always on the march and brand new. By comparison, clipping has been around since 1937. Doesn't make it any less of a valuable procedure, which I'll explain. So the big difference is between ruptured and unruptured aneurysms is what we call subarachnoid hemorrhage, the kind of bleeding that comes from a ruptured aneurysm. These are two brains. Here's a brain of a patient with an unruptured aneurysm here. These are normal blood vessels. This is what the surgery looks like. It's bloodless, beautiful surgery. It's a luxury for the surgeon. It's fun for me. And this is the brain of someone who has had a hemorrhage, which, as I reported, that's 80% of the time that the brain looks like that. That makes for a sick patient. And very often the outcome is determined by that hemorrhage. CT scans are used to show us the extent of blood. And you saw from the last patient, this is what a CT scan looks like. The white is the skull, the gray is the brain, and this white material inside around the brainstem is blood. This is an illustration of what clipping actually looks like. So you can see that round ball right there, the aneurysm, and I'm putting a titanium clip on that thing. And once that clip is in place, that's a cure. That's as though that aneurysm had never been there. It's a very satisfying and very permanent procedure. The other procedure that you need to know about is coiling. This is an illustration of coiling. So from the leg, a tiny catheter is passed all the way through the patient's body, all the way up into the head, into the brain, into the aneurysm itself. And once the aneurysm is inside, once the microcatheter is inside that aneurysm, like that, these platinum microcoils are deployed one after another until the entire aneurysm is full of platinum, which prevents the thing from filling with liquid blood. An excellent procedure. Of course, the aneurysm has to be exactly the right dimension and the right shape and such to be able to use coiling effectively. Now here is a rather unusual situation where both treatments were used at different times in the same patient. Here's a titanium clip being put on an aneurysm that was already coiled. So here's what coils look like after a year has gone by. This patient developed a little bit of what we call recanalization. That's one of the problems with coils, that the aneurysm can open up again at the base. It's not a dangerous situation, but we have to keep on the lookout for it for about 2 years. And if we see it, some other treatment is usually indicated. And in this case, it was clipping, and I was clipping the base of an aneurysm that had already been coiled. Now, I'm using this slide to make a point, and that is that the number of neurosurgeons who do both of these procedures even-handedly, sometimes during the same day, sometimes on the same patient, is very small in the United States. And I guess there are political and economic reasons for that, but since these types of coiling procedures came about in the mid-1990s, it is a little surprising that there aren't more neurosurgeons who do both of these procedures. But the way that it breaks down is most vascular neurosurgeons are either people who clip or people who coil. And the number who do both is very, very few, definitely fewer than 100 in the entire country. Obviously, it's a great advantage if you have a choice in how to treat your patient. Aneurysms are pretty much endlessly variable. So it's a very good idea if your war chest has different tools in it and you can use all of them. Here's one of the newest technologies that I thought would be interesting to show you. Here's an aneurysm of the internal carotid artery, and rather than put coils inside it, a stent is going to be placed across the bottom, but it's a special stent. It's a stent that is so fine that the placement of the stent alone, without any coils, eventually results in the aneurysm shrinking and not filling any longer with blood. Here's the stent being deployed. It's a very fine mesh. And that's the treatment. Once that stent remains in place for a little while, the blood tends to bypass the aneurysm, no longer goes into the aneurysm or goes into it less and less. And that'll be illustrated in the next frame. So blood is now very slowly going into the aneurysm, less and less, until finally it bypasses it altogether and the aneurysm shrinks away. So this is what technology can do. Again, this is not something that is the right thing for every patient, but it's good to know that it's always advancing. This is the type of operating environment where all of these technologies can be used. So in a room like this, the vascular neurosurgeon has the ability to treat an aneurysm by whatever means necessary, whether it be a clipping or a coiling or stent, all in the same room. This is the ideal environment for a hybrid neurosurgeon. And to give you an idea of why clipping is not dead, there are some cases that I will show you that even though it would have been possible to coil, it wasn't the best thing for the patient. Now, here's a patient who was helicoptered in from Merced. She had this tiny aneurysm right here. Now, this is an angiogram, okay? You inject dye into the arterial system of the brain, and you look for an abnormality. Here's the abnormality there, that little blip. That's a very small aneurysm, but it caused a very big hemorrhage. The lady was very sick. And so, I decided to use a stent in this case, and I actually put a stent in, and then I coiled through the stent. And here's the aneurysm before, and here's the angiogram after, and you notice that that little blip is now missing. Okay, this was a very effective treatment using a coil and a stent. And here's the patient. Here is now a large aneurysm. That was an illustration of a very small aneurysm that could be treated with a coil and a stent. Here's a very large aneurysm that actually, it was easy enough to start coiling it, but hard to finish. Because if you look at the bottom, here's the bottom of the aneurysm. Now you can see that filling with blood. Okay, this dye is the equivalent of blood. And you might ask, well, why can't I just fill up the rest of that with coils and make it all disappear? And the answer is that that action would result in the simultaneous disappearance of this artery and this artery. Okay, so you can't be overzealous with coils. Here's one of the problems with coils. You put in one too many and you will cause a stroke. So it seems like it's minimally invasive and it seems like it's infinitely safer than clipping, but it certainly is not and has to be used very judiciously. In this case, it was necessary to deploy a stent across the bottom of this aneurysm in order to keep the patient's normal vessels safe. And in order to do that, I went through the carotid artery of this patient, backwards through a communicating artery, and then into the artery that went across the base of the aneurysm, and I put a stent there, a stent that went from here to here across the base of the aneurysm. Just so you know, this is not something that you're going to see. This is a reportable case. You would not see this in a normal arrangement of cases. This is the kind of case that vascular neurosurgeons present at their society meetings as something very novel and unusual. In this case, the outcome was uncertain, but it seemed to work very well. The stent was in place. You see these little dots? They may be hard to see from where you're sitting, but those are the ends of the stent. The stent went from here to here, right across the base of the aneurysm, and that meant, of course, then I could go back through this blood vessel and put the rest of the coils in the base of the aneurysm. It was a very clever way to take care of the rest of this aneurysm, and here's the patient. Okay, so it's an illustration of how the technology can be used in a clever way. Technology, my message is, technology is not the answer to the treatment of these aneurysms. What is the answer is versatility, your ability to choose and your ability to outsmart the disease using all of the tools that are available. Now, here's what I was alluding to before. These are cases where we could have coiled but decided not to for the same reasons. We made a judgment call. In this case, this is the mother of one of our nurses here at Washington Hospital who had a very big bleed, very big subarachnoid hemorrhage from her ruptured aneurysm. And you can see on the CT scan, which now you're expert at looking at, that there's a ton of blood at the base of the brain. So even though this aneurysm turned out to be something coilable, the best thing for this patient was to open her skull, clip the aneurysm, and leave her skull open, which we do all the time. We have a freezer in the operating room where we put people's skulls for a couple of weeks or months, as the case may be, and that really helps people because the brain has this reaction, just like when you're punched in the eye, you go to the dentist like me and you get black eyes and a puffy face. The brain swells after that kind of a hemorrhage. It does not like the hemorrhage. So if you give it room to swell, it is much happier, and so is the patient. And I have saved thousands of patients this way by leaving the skull out. When the patient gets well, we have another operation, we put it back. So this is just a slide to show you that all of the things we do in the intensive care unit are critical. This is the IV pole of this patient with about 1 million medicines on it. We're monitoring the pressure inside the head. We're giving all these medicines to reduce the inflammation. This is a special scan that shows us the perfusion of the brain, how much blood it's getting and such. And this is what we get. This is the patient in neurorehabilitation, which is the most important part after the danger has passed. And that goes on for a couple of weeks, and then this is what you get. So this is a patient, she actually was put into a barbiturate and hypothermia coma by me. And she had her skull off so to give her brain a break. And we went after her for 2 weeks with all these medicines. We treated her for vasospasm and all of these complications. And this is what we get. It is amazing. It's an amazing thing. This is what we can do. But it requires enormous resources and attention to detail. That's what is now available to you in this hospital. So this is just a reminder slide that there will always be a role for open surgery in this type of disease, and that's why. Technology does not trump all. Clinical judgment does. And after a craniotomy, although it may seem like such a brutal thing to do to someone, it's very well tolerated, and people look exactly the way they started, like Mr. Tepper here, who remains to be handsome. Now, here is a great illustration of, I'm showing you this because I like the helicopters flying into this hospital. It's kind of dramatic for me. But this is a young woman who flew in from Modesto with a subarachnoid hemorrhage. And this is really an illustration of the use of technology, but also being smart enough to sort of see past the technology to what this young lady really needed. I'll explain that in a minute. So she lands. That is her subarachnoid hemorrhage, and it looks like there's a little more blood on the right side of the brain. And I know this is not a technical medical lecture, but just so you know, when you're looking at a CT scan, left is right and right is left, because you're looking as though you were looking up from the feet of the patient. And so if you look at the distribution of this white stuff, which is blood, it looks like there's more on the right, okay, than on the left. So you might conclude that if a patient like this were discovered to have 2 aneurysms, you would decide that it was the one on the right that had bled. Now, this is a perpetual problem in vascular neurosurgery, We've got these great imaging modalities that show us everything, but it doesn't tell us which aneurysm bled. So this lady came with great images, non-invasive, newfangled images that show us this aneurysm on the right, okay? And these are beautiful, easy to be seduced by these images, right? And they were showing us these beautiful renderings of the right-sided aneurysm, which was the wrong aneurysm, okay? Wrong target. So if you operate on a patient like this, you actually have a 50% chance of operating on the wrong aneurysm. Now, how did we find out what the truth was? You did an old-fashioned angiogram, which looks like this. And we see that this is the right-sided aneurysm. This is the left-sided aneurysm, and it has this little extra bubble on it. Can you guys see that? There's an extra little bubble there. That's called a secondary lobule. And a secondary lobule is an old-fashioned way, using angiography, to tell you that that's the aneurysm that bled. And that's how we knew. And that aneurysm was on the left side. So she got a left-sided operation. And here's her clipping. There's the clip going on. I'm going to show you that because it's such a satisfying thing to watch. Titanium clip. The original clip in 1937 was silver. These clips are now MRI compatible. So that's the end of that aneurysm. And there's the patient post-op day number 1. And then she went home, came back, and had the other aneurysm clipped, and she looks fantastic. So here's my summary. Cerebral aneurysm, a dangerous but very curable condition. We almost always treat ruptured aneurysms. Unruptured aneurysm requires a discussion. This is dangerous surgery. Coiling doesn't look dangerous, but it is. Every bit as dangerous as clipping. And you have to have a realistic discussion with your doctor about what the risks of this surgery, what the risks are, and how that balances against the risk of rupturing your aneurysm someday. Next point is that new technology is great, but it complements the older technology, which is clipping, and both are valuable. I use both. I will continue to always use both to offer the very safest treatment to my patient. Surgical versatility and the ability to use these different types of technology is absolutely critical. And most hospitals, even the big university medical centers, even though they have both types of technology available, you're going to go to one guy for one thing and another guy for another thing. If you have those people rolled up in one, that is a considerable advantage that we have here at Washington. And finally, that Washington Hospital now provides these very advanced treatment options and technologies with capabilities that are equal to and sometimes exceed those of major university centers. Some of the patients we've treated in recent months. Thank you very much.